Welcome everyone on our second webinar for patients. Today, Professor Paul van Schil from Department of Thoracic and Vascular Surgery, Antwerp University, Belgium, will talk about surgical treatment of thymic epithelial tumors.
Hello everybody, I'm Paul van Schil from the Department of Thoracic and Vascular Surgery at the Antwerp University in Belgium, and it's my pleasure to welcome you to this webinar of ITMIG, the International Thymic Malignancy Interest Group on surgical treatment of mediastinal tumors from maximally invasive to minimally invasive techniques. These are my disclosures. What exactly is the mediastinum? In fact, is a space located between the both lungs on the right and the left side. And inside the mediastinum, we find the heart, the large vessels, the trachea, the esophagus, but also the thymus, which is of major interest to us. When a tumor develops inside the thymus, we call this a thymoma. But other, quite different types of tumors are also possible. For example, tumors of the lymph nodes, of connective tissue, germ cell tumors, and some rare tumors of the heart have been described. When we talk about surgical treatment for these mediastinal tumors, we can do it from several techniques, going from maximally invasive to minimally invasive techniques. Maximally invasive are sternotomy, so opening up the sternum, which is the bone in front of the heart and the large vessels. From the lateral side, it's a thoracotomy, and a bilateral thoracotomy is a clamshell incision, and I will show you examples of that. So these three are the maximally invasive techniques. Recently, also minimal invasive techniques have been developed as looking inside the chest or thoracoscopy, which is called VATS, video-assisted thoracic surgery, or we can do it by robotic techniques, RATS, robotic-assisted thoracic surgery. First of all, median sternotomy, so opening up of the sternum. Indications are cardiac surgical procedures, so operations on the heart, but also in case of a bilateral lung resection, for example, patients with lung metastasis, we can do it by median sternotomy. Also, mediastinal tumors, which are located in front of the heart and the large vessels, which we call pre-vascular tumors, are a good indication to be operated by median sternotomy. Regarding anesthesia, when we have to do a procedure on the lung itself, we will ask the anesthesiologist to insert a double lumen endotracheal tube to ventilate the left and the right lung separately. Also, we will ask for a thoracic epidural catheter for adequate pain control after the intervention. So this is the median sternotomy, opening up of the sternum with the saw. Both parts are divided and separated by a spreader. So this is a case of a 54-year-old female patient who was investigated because of cardiac insufficiency, and a cardiomyopathy was diagnosed, meaning that the muscle of the heart was not functioning very well. On the chest CT scan, a tumor of 11 centimeters was found on the lateral part of the heart, extending into the anterior part of the mediastinum. So we operated this tumor by median sternotomy. The head of the patient is over here, the feet are over there. So we opened up the sternum and then the pericardium. The pericardium is the envelope of the heart itself. So the tumor, in fact, was inside the pericardium. You can see it's a large tumor composed of blood vessels. We completely removed the tumor, put it on the thymic board, which makes it easy for the pathologist to have a correct orientation of the specimen. And this was a hemangioma, meaning an enlargement of blood vessels, but in fact it's a benign tumor that was completely removed. So no adjuvant treatment was given to the patient. The second incision, when we go from the lateral part of the chest, is called a thoracotomy, so opening up of the chest. In this case, we had to make a quite large incision on the lateral side underneath the scapula, which is signed off here. On the lateral side, we find the muscle latissimus dorsi, so in fact is the largest muscle we have on the chest. More anteriorly is the serratus anterior muscle, of which is divided to gain access to the chest. So this is a lateral thoracotomy. We try not to divide the latissimus dorsi muscle, but pull it backwards in case we need this muscle for later reconstructions. So this is the serratus muscle, shown over here, and underneath we find the ribs and the intercostal muscles. Then the intercostal muscles are cut. We go in between those two ribs, we put in a spreader, and then we have a nice access to the chest. This is a 54-year-old male patient who was investigated because of chest pain and continuous cough. On chest CT scan, a large tumor was found in the left hemithorax, so more on the left side from the heart. The heart is over here. This is the aorta, our major blood vessel inside the chest, and this is the tumor. It's more difficult to approach it from the anterior side by sternotomy, so we prefer to do it from the lateral side by a lateral thoracotomy. This is a frontal view. You can see the heart over here, the large vessels, and the tumor located on the left side. This is the liver and the diaphragm, which is the muscle between the chest and the abdomen. The tumor was completely removed. This is what remains of the thymus, and this is the tumor itself. This was a thymoma B1, which was completely removed, so no adjuvant treatment was given to the patient. The largest incision we have in the chest is called a clamshell incision, and clamshells are shells found on the Pacific coast of the USA, and you see an example of that over here. So in fact, it's a bilateral, so meaning on both sides of the chest, the thoracotomy. We open up the chest on both sides and we cut the sternum, so the bone, but now transversely, not longitudinally as in a classical median sternotomy, but transversely as shown over here. And so we have access to the mediastinum, but also the heart and both lungs. I show an example of a 61-year-old female patient who was investigated because of diffuse muscular complaints. And we found incidentally a large prevascular tumor in the mediastinum. On cardiac ultrasound, there was no invasion of the heart. There was an enlarged left ventricle, but a good function of the heart itself. EMG or electromyography was strongly suggestive of myasthenia, so muscle weakness, which is associated with thymomas. On the PET scan, there was a slight uptake of the isotope in the anterior mediastinal tumor and diffuse tracer uptake in skeletal muscles of the arms and also the lower legs. And the question was whether this was paraneoplastic or not, meaning associated with a tumor. This is the PET scan showing the large tumor on CT scan with some uptake of the isotope here on the specific PET CT images. So this is the tumor seen from the lateral side and here seen from the frontal side. And this is the uptake in the muscle of the arms, also shown in these images. You can see there's uptake of the isotope, especially in the arms, but also in the lower legs. A transthoracic puncture was performed, which was suggestive of a cortical thymoma, so a thymoma. As this tumor seemed to be operable, so resectable, we did an enlarged thymectomy, so extended operation by clamshell incision, opening both sides of the chest, giving access to both lungs, also the mediastinum and heart. So this is the large tumor on the right side of the chest. We had to open up the pericardium, which is called an intrapericardial dissection, and we also had to remove a small part of the right lung, which we call a wedge excision. So this is the tumor that was completely removed by a clamshell incision. So this is the resected specimen, the tumor, the small part of the lung over here that was removed, and this is the thymus, the rest of the thymus that was removed together, which we call en bloc removal with the tumor. So this was an extended thymectomy, and pathology showed a cortical thymoma B2 with capsular invasion. Postoperative recovery of our patient was uneventful, and she was treated by postoperative radiotherapy due to capsular invasion. So that was part of the maximally invasive techniques, and we now go on with the minimal invasive techniques. First of all, VATS, video-assisted thoracic surgery or thoracoscopy, meaning that we make smaller incisions, about 1.5 centimeters, on the lateral side of the chest. We introduce a camera, a scope. We can follow everything on the monitor. So in fact, we operate on a TV screen, and then we can, by other ports, we can introduce instruments and operate inside the chest. The disadvantage of this is that we only have a two-dimensional view, and that we are limited by the instruments we can use. So for this reason, more recently, robotic techniques were introduced where we operate. This is the older version of the robot with robotic arms, which are inserted by what we call thoracoports in this patient on the right side of the chest. And I will show an example of a robotic procedure. So we make smaller incisions, insert the ports, and then the robot is connected to those thoracoports. We operate on site of the patient with a console. These are called the masters to control the robotic arms from a certain distance. So now the ports are inserted. We first look with the camera whether it's feasible to do the operation with the robot. You can see on the screen over here a large tumor in the mediastinum. These are the robotic arms which are connected to the patient by way of the thoracoports. So now the robot is in place, and you can see it's rather hard to find the anesthesiologist which is behind the robotic arms. So we are operating on the console. One of our residents is at the operating table in case other instruments have to be introduced or when we have to switch the camera with other instruments. This is a 48-year-old female patient with myasthenia gravis with positive antibodies against acetylcholine receptor, and these antibodies are secreted by the thymus. EMG gave our confirmation that this was myasthenia gravis, and on chest CT, a mediastinal tumor was found in front of the large vessels. This is the first image of the CT scan showing the aorta, the superior vena cava, and in front of the large vessels, we find the tumor in the mediastinum in the region of the thymus. So this was compatible with a thymoma. You can see that there are some calcifications inside the tumor, which also a sign of thymoma. So this is already the heart behind it. This is the aorta, and then we have posteriorly the vertebral column. So this patient was operated with the robot from the right side. So the right lung was not ventilated during the procedure. Then we could introduce the camera, and the robot has a double camera, meaning we have a three-dimensional view when we operate, which is an advantage in contrast to a classical thoracoscopy. So this patient was operated from the right side. We had a double lumen endotracheal tube, so the right lung was not ventilated. You can see there were some adhesions with the pericardium, so the envelope of the heart shown over here, and it is the tumor itself. So we go around the tumor, we try to encircle completely the tumor, We go inside the mediastinal fatty tissue. So the robot has a magnification of approximately 10 times. You can see the white nerve over here is the phrenic nerve, is a nerve going to the diaphragm, so the muscle between the chest and the abdomen. So in most cases, we try to spare the nerve as it's an important muscle, the diaphragm. It's an inspiratory muscle, so quite important for our respiration. The head of the patient is on the left side over here, and the feet are there. So this is the right lung, with here the tumor itself. So we dissect further inside the mediastinum, we are on the right side, going to the left side. This patient had myasthenia, so it is important to completely remove the thymus, which we call an extended thymectomy. So we dissect now the mediastinal region, and these are the thymic extensions going almost to the neck, and these are closely connected to the thyroid gland. So we carefully pull on those extensions, so the cervical poles of the thymus, and there are two of them, one on the left side and one on the right side. And as you can see, due to the magnification of the robot, we have a very nice view, and we can even see details we cannot see with our own eyes. The smaller vessels, the smaller branches, mostly those are veins going to the thymus, are dissected, and we can put clips on them, as shown over here. So an additional instrument is inserted. We clip those veins, and then we can divide it. Clips are also useful for areas where we are not sure that the tumor was completely removed, in order for the radiation oncologist, when radiotherapy is necessary after the operation, he can exactly find the locations where probably tumor could still be in place. So we now dissect the pericardium, as you can see over here, but the pericardium was quite thickened and we could not completely separate it from the tumor. So we open up the pericardium, which, as you can see, is fairly easy to do with the robot, and we'll remove part of the pericardium, so which is quite thickened, as you can see over here, with the robotic instruments. You see the heart beating here. It's the right side of the heart, we can see. As it was a very thick pericardium, we introduced robotic scissors to cut the pericardium and to coagulate the smaller blood vessels, so to obliterate smaller blood vessels. You get a nice view of the pericardium over here. And then we go to the left side. You can see we open up the pleura, and you can see the other lung coming up. It's the left lung. In order to completely remove the thymoma, the tumor, with pericardium and part of the pleura. So we have dissected the upper part of the thymus. We go to the left side, and then lastly, we go from the distal part, from the caudal part, we move upwards to completely remove the tumor. This is the tumor on the thymic board. You can see the extensions going up to the neck and complete removal of the tumor. Pathology showed this to be a thymoma B2 with a diameter of 7 centimeters. There was capsular invasion but clear margins. So this patient was given post-operative radiotherapy for 66 grays, so meaning a course of 6 weeks. The further post-operative course was uneventful. On follow-up chest CT, there was a normal post-operative status with some fibrosis due to the radiotherapy. So this is a follow-up chest CT after the operation, again showing the large vessels. You can see there are some adhesions behind the sternum where the radiotherapy was given, but the thymoma has not recurred, so there's no evidence of recurrent disease. So this is the heart, the aorta, and you can see the anterior mediastinum is quite clean. So in conclusion, regarding the surgical treatment of mediastinal tumors, we can do it maximally invasive by sternotomy from the anterior side for tumors in front of the large vessels in the heart, by thoracotomy, for example, for tumors located on the lateral and the posterior side of the chest. We can now do it also in selected cases by minimal invasive approaches, so VATS or RATS, video-assisted thoracic surgery or robotic-assisted thoracic surgery. In case of a thymectomy for myasthenia, which is benign, in case of thymic hyperplasia, benign tumors, for example, thymic cyst, or as I showed you, for selected thymomas, usually not larger than 4 to 5 centimeters. But in fact, we have to discuss every patient within a multidisciplinary team and adapt to the patient and his specific lesion. And as my last slide, I would like to show you our new port office building in Antwerp, Belgium. The architect is Zaha Hadid, and in fact is a brand new building built upon an old fire station, showing that we have here a combination of old and new. So as a surgeon also, we have to study to learn the older techniques which we apply in some instances, but also be aware of the newer developments in surgery in the interest of our patient and to decide the best approach for our patient. I thank you for your attention and I'm happy to answer any questions you might have. Thank you for your attention.
Paul, that was a fantastic talk. Sorry I joined late. This is Usman Ahmed from Cleveland Clinic. I'm one of the thoracic surgeons, and I want to congratulate Dr. Van Schil for this really nice summary of the various techniques that we have at our disposal to allow us to really choose the right operation for the right problem and for the right person. It's not the same hammer for every nail. These are tough surgeries, tough problems. Choosing the right place to go to, the right surgeon, the right expertise, or I should say surgical group, that also involves their radiation colleagues and medical oncology colleagues and radiation oncology colleagues and pathologists is really key. And that's why part of the reason we've suffered in taking care of thymic tumors is that they're rare, and if rare tumors are taken care of at hospitals and centers where they don't see a lot of them, then that rarity leads to even further complications in their treatment and iterations that particular place may not be familiar with. So that was a very nice summary. Paul, I'd be very happy to hear if your office is on top of that building, I'll come and visit you if that's the case. But anyways, we'll be happy to take any questions.
Thank you, Isman. No, it's the port office building. It's for the rich people having access to the port. I'm a small office. I have a question over here, and it's quite a difficult role. Is there a role of doing a thymectomy when the primary is small, 3 centimeters, but there are extensive liver metastases and no other metastases? I think in that case, we first should go for systemic therapy or a combination that we remove the thymus, but also we should do then a more extensive resection or radiofrequency ablation of the liver metastasis. When there are extensive liver metastases, I think the prognosis of the patient will depend on the liver metastasis, and in that case, it's not really useful to do a thymectomy. Do you agree with that?
Absolutely. So, when there's disease in multiple organs, by definition, that's systemic disease. And the first line of treatment when any cancer of any sort is in multiple organs should be a treatment that goes everywhere and tries to control the disease. And that's systemic therapy of chemotherapy. Now, immunotherapy is coming into play, not as much in thymic tumors, but it does have some role. So a multidisciplinary discussion, as Dr. Van Schil pointed out, where the surgeon and the oncologist and the radiation oncologist sit together and create a plan that is titrated towards dealing with that situation is the best way to go in these situations. But yes, all three options of surgery, radiation, and chemotherapy have a role in situations like this. What exact combination it's going to require depends on the specific situation. So there's another question, Paul, about subxiphoid thymectomy. Would you like to make a comment on it?
Yeah, I didn't mention it because the talk, in fact, was on mediastinal tumors. We don't have much experience with subxiphoid thymectomy, as I think in some patients it's quite difficult to go up in the anterior part of the mediastinum until the neck, and especially for tumors that are close to the pericardium, to better judge whether there is invasion of larger vessels, I think it's very difficult to do it by a subxiphoid approach. It can be useful, however, for thymic hyperplasia in case of myasthenia, but it's not our preference for mediastinal tumors itself, because the evaluation is less extensive than when you do it by VATS. I know some combine it with a VATS approach, a lateral VATS approach, and subxiphoid incision. But for mediastinal tumors, we prefer to do it by RATS or large incision when there's some doubt about invasion of pericardium or the larger vessels.
I would agree with that. So subxiphoid thymectomy particularly has developed a role in Asian countries where the body habitus is a bit more amenable to that type of approach. But the goal of doing a thymectomy in myasthenia gravis is to remove all thymic tissue from both sides of the pericardium, and limiting this to a small approach coming only from below and the underside of the sternum can sometimes jeopardize that goal. So at the Cleveland Clinic, we actually do bilateral approach in these situations so that we get every little piece of thymic tissue from under the phrenic nerve on both sides. So I do bilateral robotic approach with 3 tiny incisions on each side, and so we can really see both phrenic nerves and remove all tissue. So there's another question about myasthenia gravis 8 weeks after thymoma removed by rats and 6 weeks port. I'm not sure I quite understand that question, but thymectomy can be performed after radiation therapy. In fact, in some of these examples that Dr. Van Schil showed, if these were more aggressive tumors, these patients would have had chemotherapy and radiation before surgery, and then we would take them to surgery to remove the remnant tumor and do an extended thymectomy. So having had radiation does not exclude the possibility or preclude the possibility of having surgery. Again, we would have to look at the details of the situation to really comment on it in further detail. And if you would like to explore that further, you could email us and one of us would be happy to look at the situation in more detail. There's another question about thymoma 4 centimeter by 2 centimeter encapsulated. Cannot have robotic surgery yet, is too large, using sternotomy to remove the entire thymus. So well, I'll let Dr. Van Schil address that first before
I think a tumor of 4 centimeters, usually you can remove it by rats, but it also depends on the location. When it's nicely encapsulated in the mediastinum and there's no concern, especially around the brachiocephalic vein, so the large vein going to the superior vena cava, I think you can do it by rats. If there is a suspicion that the tumor might invade a brachiocephalic vein or the superior vena cava, I think then sternotomy is the better way to go inside the chest, as you can better evaluate and reconstruct those veins in case it would be necessary. So we have seen some cases that were referred to us where rats was tried when there was invasion of the vein, then an incomplete resection was done, and then afterwards you have to go in again to remove the remaining tumor. And I think that's not a good operation, because as I mentioned, complete resection is really key in those patients with thymoma, not to have any spread inside the mediastinum of the pleura. So it depends on the location, but in general, a 4 centimeter tumor that is completely encapsulated, in our opinion, can be removed by rats unless there is concern about invasion of the larger vessels.
So I would agree with that. Size by itself is not a criteria in deciding those techniques. You can easily remove tumors like Dr. Van Schil said, up to 7-8 centimeters through minimally invasive approaches. After that, in the incision that's going to require to remove a tumor bigger than that is about the same as doing a thoracotomy or sternotomy, so it doesn't make sense to do the surgery minimally invasively. But at that size, it should be amenable to it unless there's some other circumstances, such as involvement of vessels that may require a larger incision. The question of what your surgeon decides to do, it's hard for us to comment on that. The golden rule of surgery that I tell my patients is that if you are comfortable with your surgeon, then let them do what they've decided is best, it works best in their hands. If for some reason they've decided to do a sternotomy on you and in their hands that gives the best results, and you're comfortable with your physician team, then there's absolutely nothing wrong with that. Sternotomies have been the standard of care in this operation for the longest time period. We certainly have more minimally invasive approaches, but again, everything has to be titrated to the exact clinical situation. So I would discuss with your surgeon in more detail if those possibilities are available for you. And the question after this is similar to what Dr. Van Schil referred to. So that the completeness of surgery is very important. Excuse me, the completeness of resection or removal is very important. The difference between R0 or R1 really can sometimes be impossible to tell during surgery. During surgery, we always try to go stay inside the capsule of the tumor and do a maximal resection whenever possible. And Schil showed some of those examples of pericardium and with the tumor. But the ultimate gold standard of whether the tumor has been completely removed or not remains in the pathologic evaluation. And if an R1 resection, which means the tumor cannot be seen at the edge of the resection with naked eye, but can be seen close to the margin microscopically, then that is what we have to go with. And in that case, further therapies would be warranted, such as port that Dr. Van Schil referred to earlier.
Yeah, I think it's a good question, Usman, because sometimes we have to discuss with the pathologist. Sometimes you have a tumor that invades the capsula, but the lung is not adherent to the tumor, and the pathologist might think that the margin is positive, but in fact it's not a margin because the lung was not adherent. So I think we really have to discuss with the pathologist to see whether this R1 or R0 resection. Sometimes they have inked on the surface and they say that surface is invaded, but in fact the lung was not adherent to that tumor. So in fact it's not an R1 resection, but it can be called R0 because there was nothing left behind.
Correct. So when it comes to mediastinal pleura, there's pleura and then the lung starts, and the two may not be attached to each other, but that's where the tumor finishes. So it becomes very hard for the pathologist to make that conclusion, in which case, again, the physician team has to reach a consensus together. That's very well said. However, recurrent thymomas removed, they can be removed thoracoscopically or robotically, but again, that's not a rule written in stone. My personal advice to patients is that how your surgery is done, whether it's through one big incision or 3 small incisions, you're going to forget about all that in 4 to 6 weeks. But what is done inside is what matters the most. It has to be a good operation on the inside, meaning complete removal of the tumor, whether it's done minimally invasively or maximally invasively. Let your physician and surgeon decide. In my mind, from a cancer care standpoint, that is a secondary consideration. Although we do most of the resections minimally invasively these days, I always tell my patients that if I feel during surgery that sternotomy is the right thing to do, that things are too stuck or tumor is growing into a blood vessel, then I would not think twice before performing a sternotomy or a thoracotomy, what have you. Paul, you want to comment on that?
No, I think I agree completely. I think we should realize that VATS, RATS, or other approaches are just an approach to the tumor, are not an operation in itself. So the operation consists of what is remaining has to be completely removed. And when you feel comfortable by VATS or RATS, you can do it. If this is not the case, then we choose for a larger incision. And in some cases, recurrent thymomas are sometimes very difficult to remove, to completely remove them. In case a patient did not have any radiotherapy, we will place clips around the resection margins. And in some cases, sometimes we even start with radiotherapy. Sometimes we give it as postoperative adjuvant therapy. But I think for recurrent thymomas and especially thymic carcinomas, every patient has to be discussed, and there are no general guidelines to give, but it's a combination of chemotherapy, radiotherapy, and surgery in the interest of trying to remove the recurrent disease.
So there's a question about thymic carcinoma that appears to involve a few blood vessels and has metastases in the lungs. You know, this is a situation where the cancer, the thymic carcinoma, is in multiple places. So once it starts to surround blood vessels, it makes the surgery quite challenging. A lot of times when we go to do these surgeries and look inside the chest, the involvement is more than what it appears on CT scans. So you have to resect more, remove more. As a basic principle, doing a massive operation and leaving cancer behind does not help anyone. And that is the first sort of pass that we surgeons take when we assess these difficult situations. When we think that we're going to be able to remove 90% of the tumor and leave 10% behind, but on the other hand, we're getting all the risks that are associated with doing a big operation, then doing a big operation is usually not worth it, in my opinion. And we should look at therapies that can address and treat the problem through other modalities, such as immunotherapy, radiation therapy, chemotherapy. So for a thymic carcinoma that has this type of clinical picture of extensive vascular involvement and lung metastases, our bias at the Cleveland Clinic and my bias would be to think about a good systemic therapy option, such as chemotherapy, immunotherapy, with or without some combination of radiation therapy. I'll let Dr. Van Schil share his opinion.
No, I completely agree. I think this is a stage 4B tumor. So in fact, it's impossible to remove everything. And especially when it's close to the aorta, I suppose it's the arch of the aorta and the superior vena cava. Reconstruct those large vessels is only worthwhile when you can completely remove the tumor. But when you have lung metastasis, those are really considered to be distant metastases in contrast to pleural metastases, who are more local regional spread of the tumor. But really, lung metastases are distant metastases. So first we should go for a systemic therapy and then look at the response and see whether it's possible to completely remove the tumor afterwards, but not starting with surgery. I don't think it's a good idea to do it.
We have another question about stage 4A B1 thymoma and recurrence. So stage 4A, if you think about it, for all cancers, as you probably know, this staging is done in a fashion where stage 1 is tumor at a very early stage only in one place. Stage 4 on the other end of the spectrum is tumor in multiple places. So in thymic tumors, they're relatively slow growing. We've divided stage 4 into A and B, where A is where there's extra spots in the pericardium or along the lining of the lung, the pleura. And 4B is where there's metastases in the lung or outside the chest in other places such as liver and bone and so forth. So stage 4A is pretty extensive disease to begin with. If it has been completely treated and there's no disease left with some combination of chemosurgery, with or without radiation, there is still a reasonable risk of recurrence, and that is why surveillance for these situations is very important with CT scans, PET scans, and so forth. So to broadly answer your question, I don't think it is uncommon to expect a recurrence for stage 4A thymoma, and that's something that the treating team should be prepared for in these situations. Paul?
Yeah, I would like to add to that even for type A thymomas, there's no variant that's called atypical type A thymomas, and we recently had 2 cases of that. The patients coming with diffuse metastatic spread. Even we had a young female patient who got pregnant, And during the pregnancy, she developed pleural metastasis of type A thymomas. And until now, she had 4 operations. And I had to end with a pleuropneumonectomy on the left side to completely remove metastatic disease. Although under the microscope, it looks like rather benign disease. It's type A thymoma. So it's not only depending on the type. We have atypical type A thymomas. So especially stage 4A, those patients will develop quite a lot of recurrent disease.
Right. So I am personally not going to comment on the ketogenic diet. It's not my area of expertise, and from everything that I know, there does not seem to be any association with dietary intake and progression of any cancer that we know of. The only dietary associations that we know of is with esophageal cancer and inhalation of nitrous substrate, ingestion of nitric-containing substrates. That's usually seen in Far East Asia. Outside of that, I won't be able to comment on that association. Dr. Van Schil, would you like to add to that?
No, me neither. It's outside my specialty. As you, I'm a surgeon, but I'm not aware of any diet that is given by a neurologist or medical oncologist to patients with thymomas.
And what would you like to comment on the immunotherapy question?
I think the first preference is, when you can do a complete resection, is to go for surgery. In case of thymic carcinomas or those that thymomas that are not resectable from the start, we still like to use chemo or chemoradiation at the beginning. Those patients have recurrent disease. We have a trial running with the ERTC of immunotherapy, but it's not the first treatment to give to patients with operable disease in our center. I don't know in yours.
So similar. So I think mostly around the globe, we're learning the role of immunotherapy in thymic tumors. The role is certainly a lot more established in other cancers of the chest, such as lung cancer, mesothelioma, esophageal cancer, and so forth. The problem with thymic tumors is that, as you know, they're full of immune cells. So the immunotherapy relies on revving up your own immune system to fight the cancer cells, and the two don't get along very well. So there's a lot of toxicity that is seen in thymic tumors and not as much response, but there's a clear role of immunotherapy in advanced thymic carcinomas. In advanced thymomas, we're still learning and trying to figure out the immunotherapy agent that would allow us to have a response similar to what we now have in our arsenal for lung cancer and so forth.
Yeah, and especially in patients with myasthenia gravis, we should be rather careful with immunotherapy, I think.
Absolutely, but that's a very good question, and you should, you know, for anybody who's seeking treatment, asking for available clinical trials is always a good idea.
Yes. And we have a question, I think, about mistletoe therapy, or?
Yeah, unfortunately, I don't think I'm smart enough to answer that.
No, I just can say we don't use it, but I don't know whether there are some data to defend this therapy or not.
Margaret, would you like to comment on, you know, the role of a pathologist and how it's important that the surgeons and the pathologists talk to each other when these situations arise, particularly when they were trying to figure out the margin situation?
Thank you. Frankly speaking, you said everything about this cooperation, and I absolutely agree, especially in terms of surgical margins. For us, it is very difficult very often to find surgical margins. What actually is a margin in thymic tumor? As you told before, and I absolutely agree, not each surface of the tumor is a true margin, and pathologists must be aware which surface is a margin and which surface is just, for instance, mediastinal pleura. Without good cooperation between surgeons and pathologists, we may have really problem where these margins should be found. And of course, first we start our analysis on gross examination. So we analyze the whole tumor, we look at the surface. But if there is a focus, we are not sure, we must be informed by surgeons. Is it a true margin or rather not? This cooperation between pathologists and surgeons is that's why it is so important. It's great if surgeons use such graphics like was shown during presentation. Unfortunately, not in all institutions such graphics are used. It's a pity, but there are also other methods. Surgeons sometimes mark margins with ink or just use stitches to show more important areas. But for us, it is really, really very important, especially in thymic tumors, because thymic tumor is, when we receive thymic tumor, we even can't guess where is right, left side, top, bottom, because this tumor can be located at any way. For instance, if we receive a lung after resection, we can adjust this organ because we know the anatomy of the lung, and we can guess this is the top, this is bottom, right and left side. It's absolutely impossible in thymic tumor where we know nothing about it. That's why this cooperation is so crucial between surgeons and pathologists. I can only add about, because there was a question about immunotherapy, so I can add, today we are talking about surgery, but please visit our webpage regularly, because we are going, in April, we are going to talk about radiotherapy, and one of radiation oncologists confirmed a webinar. And later, in May, we will be talking about chemotherapy and immunotherapy in thymic tumors treatment. So please visit our webpage. Next webinars will be dedicated to radiation oncology and chemotherapy and immunotherapy. So that was information for patients. Thank you.
Thank you, Margaret. That was really nice. So couple of things that I would like to point out to sort of wrap up this issue is that, as I mentioned before, these tumors are rare. In a hospital where they maybe see 2 a year, it can be quite challenging to come up with a treatment plan that remains that is systematic. And that is why an association like ITMIG has really raised awareness in the world, and all of you who need any guidance are more than welcome to reach out to us. Your physicians can reach out to us, and we run what we call ITMIG tumor board. So just like every hospital has a tumor board where complex situations are discussed, ITMIG physicians come together to discuss tumor boards from problems all around the world. We've discussed cases from Canada, from North America, from South America, from Asia. And if you feel that there is any such situation, you can always ask your treating physicians to contact ITMIG leadership, and we'll be happy to look at those cases and discuss them in our tumor board. There's a question about if there's any drugs available to prevent recurrence. Unfortunately, if a tumor has been completely, well, fortunately, if the tumor has been completely treated with surgery, radiation, chemo, or some combination of it, there's really nothing that we add now to prevent recurrence. If obviously the tumor has not been completely treated and there's still active disease, then chemotherapy or immunotherapy would be the way to go. There's another question about, well, thank you. We've enjoyed your company also. Now, the one thing I'd like to add on that surveillance aspect is that we have a world famous radiologist who's participating in this webinar. So what happens to cancer treatment doesn't stop after surgery or after chemotherapy and radiation is finished, but a very important part of this process is keeping an eye on the disease to see if it comes back or when it comes back, and how we diagnose it in time to again treat it appropriately. I tell my patients that you have to think of this as a chronic illness. This is like diabetes. It almost never goes away. You just have to keep it under control and keep moving forward. And after definitive treatment of thymoma or thymic carcinoma, whether it's with surgery or chemoradiation, we do continue the surveillance protocol. So if she's available, I would like to invite Dr. Edith Merrim to make a comment about the surveillance routines and what we know and what we don't know after a thymic carcinoma or a thymoma has been completely removed or treated.
Hi, glad to hear this wonderful talk and the discussion. So yes, the surveillance after removal of a tumor is basically tailored to each individual, and it depends on the stage, meaning how widespread the tumor was in the beginning, and also how long we are since the resection or the attempted resection. So if the tumor is more aggressive, like thymic carcinoma, or if the tumor was more widespread, then after the initial surgery, imaging is done earlier on. And again, it depends. I don't want to even say months or anything, because it depends on what your clinicians felt. But it's at least once in 6 months. Some places in the first year do once in 3 months, but once in 6 months for at least the first 3 years. And if there was no change, then there is a tendency to take greater intervals, so that until year 11 after resection, if it is quiet and there's no resection, some people think, well, how often should I even continue following after year 11? Should I go to chest radiographs once a year instead of chest CT scans? Sometimes doctors and patients will decide after a long time has passed, years, to sometimes do an MRI instead of a CT. But again, it's tailored. But the minute there is a recurrence, or if you are under chemotherapy, then you need closer tabs on what's going on. So normally it would be while getting active therapy, it would usually be every 3 months. But the surveillance, when we speak about it, it's more widespread. It's when disease is quiet, when there's no recurrence. It's just to see if things are growing, if there is a recurrence, because there are effective therapies with this disease. Thank you.
Thank you, Edith. And there's another question pertaining to that. So the risk of doing CT scans and the associated radiation for surgery.
Okay. So, the fear of the risk of radiation from CT is a little bit out of proportion, I must say. You know that when there is residual disease and we treat it with radiation to kill the disease, we use, more than 1,000 times any CT from any radiation from a CT. The radiation associated with CT is very, very low. And also, even if you take examples of young people that get tumors that people get when they're in their 20s, even then, when the 95% of them, it doesn't even affect the length of their lives, it's still worthwhile to get a CT, because you have to ask yourself, why am I getting this CT? Am I healthy? Am I getting it for no reason? Or if I see something in my CT that can be acted on, will it elongate my life? Will it lengthen my life? Will it save me? And the answer is that with thymoma, when there is progression of disease, there is a change of management. It could be a change of chemotherapy. In some cases, it could be resection. And we know that that does elongate life. So even if it was associated with an increased risk of another cancer or death, it would have been useful. But I want to explain something about this radiation and everything. So the knowledge that we have that radiation can cause cancer does not come from medical imaging. It comes from Hiroshima and Nagasaki. And we know that from an amount of radiation that's called 1 gray and above, in a linear fashion. The more you get, the more cancers you get. And that's if that person got that radiation all at once. But that's not the situation with medical imaging. With medical imaging, the amount of radiation about is 1/1,000 of that. There is no data to suggest that even 1/100th of that 1 grade causes any cancer. And even when the people get a lot of radiation, the cancer occur not a lot like in Hiroshima and Nagasaki, but from other sources, not from the regular medical imaging, much more. The cancers that can develop don't happen immediately. They happen 30 years later, 40 years later. So again, from the CTs that you get for the follow-up of thymoma, no, there is no proof that it causes cancer. But even if it was much more than that, when people with thymoma and thymic carcinoma are usually not 18 years old when they get the tumors. Usually they're around 50 to 70 years old. So the fear of getting any cancer is really not even realistic.
Thank you, Edith. So there's a question about the growth of tumors. In general, thymomas are very, very slow growing. So by the time a 4-centimeter thymoma is diagnosed, it's probably been there for something like 3 to 5 years, if not longer. Thymic carcinomas grow at a slightly or at significantly faster rates, more closer in the spectrum to lung cancer than thymic tumors. Let's see. So does radiotherapy cause a lot of internal scarring? So why don't we ask Dr. Van Schil to answer that, since he operates on cancers after patients have had radiation therapy. So lung, esophagus, thymic tumors.
Yes, I would like to add to that it's important the time interval after the radiotherapy. When it's only a few weeks, I think usually the surgery is feasible. But when you have had radiotherapy months or even years before, then your mediastinum can what we call be frozen. That sometimes it's almost impossible to dissect the vessels inside the chest, especially the pulmonary artery, when you had long-standing fibrosis after the radiotherapy.
It's a very good point about time, but certainly time in any of these things by themselves do not preclude surgery. So yes, we're in an era now where patients are living much longer as compared to 10, 15, 20 years ago. So we're seeing patients who've had radiation 20 years ago or 10 years ago, and now they have a recurrent cancer or a second cancer. We see this more commonly in the lung cancer space, and surgery still remains an option. It's a high risk operation, but it does remain an option in those situations as well. And Dr. Maram shared some information about the radiology related radiographs related radiation. You guys are welcome to visit that. What's the question about CT contrast allergy? Yeah, we usually think it's okay. At the time of diagnosis, when we're planning treatment, contrast studies are more important as we need to look at vessels and so forth. MRI certainly can be very helpful. For the sake of surveillance, the added benefit of IV contrast, we can probably do away with it, but I'll let Dr. Maram comment on that.
Yeah, so let me explain. The people on the talk, all the patients that joined or the patient advocates probably already know that thymoma has a tendency to invade vessels and has a tendency to go into the pleura, that's the lining around the lungs. And if it's stage B, if it's more advanced, it has a tendency to go to other organs like the liver, for example. So in the beginning, before the first surgery, if the thymoma looks advanced to begin with, we have to use some way of imaging so we see the vessels great, because the last thing we want is for the surgeon to go to surgery and let's say they decide to do a robotic or whatever they decide, whatever the way they decide to do the surgery, and have a surprise and suddenly unprepared find out that the tumor goes into vessels and now it's become a much greater tumor and they need to replace vessels. That's the last thing you want, is a surprise at surgery. You want to be prepared for the worst case scenario, and you need as much information as you want. So if we don't give contrast, we cannot even see if the tumor invades a vessel that it abuts. And if we don't give contrast initially before the first surgery, then we cannot even see if in organs that look just the same as the thymus, like the liver, like the adrenal glands, if there's metastatic disease there or not. So for the first imaging, it has to be perfect. So if there's no way on earth one can get iodine, because there are ways to overcome small allergies, but let's say the allergy was really bad, then what one does is replaces it with an MRI, because the MRI uses a contrast that's not iodine. So whoever is allergic to iodine is not allergic to the contrast in MRI, and that's one option. Now, as far as the follow-up, as I said before, I was a little careful because the follow-up is tailored to each patient. So let's say a patient had a tumor removed and it was relatively early. There was no super invasion next to the organs and next to where the tumor was. And we don't expect there to be much of a recurrence. There's not much left there anteriorly, just lungs. So the lungs are very easy. Anything around the lungs is very easy to see without contrast, because the lungs are black and anything that looks like tumor is just white, easy to see. So in that case, when it's relatively limited and all we're looking for is just with the tumor bed or the lungs or the pleura, fine. Maybe we could do without contrast. But if we want to see clear to areas that have the same consistency, if the tumor spread to the pleura and from there to the diaphragm and the liver, we're going to have to use contrast. So if there's no way on earth you can get contrast, then you can get an MRI. But again, it's really tailored to what stage and how was the tumor bed after surgery. Was all removed, not all removed? So it's very much tailored to a specific patient and what stage it was and what we expect. And if we have any questions, even if we chose to do a CT without contrast, if any question arises, we can always add an MRI for a specific question if we're not sure of ourselves.
Thank you, Edith. So I think we're out of time. I'll let Margaret finish up. But if you have any questions, anyone else, any scenarios come up where you think you need a second opinion, third opinion, we're all here. The society was formulated for this exact purpose because things aren't very clear. In a general thoracic surgical practice or medical oncology or radiation oncology practice, the number of times a single physician encounters a complex thymic tumor is perhaps a few times a year, unless you're at a big cancer center. So if you feel like you need to have a second or third or fourth pair of eyes to look at the situation, please reach out to Ms. Pam Bruce, who's been fantastic in organizing this whole effort. And we're at your beck and call. But I'll let Margaret take it from here.
Thank you very much. So I would like to thank all participants, thank Dr. Van Schil for perfect presentation, Dr. Ahmad for excellent moderating of the discussion, and Dr. Marom for all comments. And of course, I'd like to thank our patients, participants. Thanks for your questions. And let me tell you again, please visit our webpage, because we have at least 2 next webinars confirmed. One in April about radiotherapy, and in May about chemotherapy and immunotherapy. So visit our webpage and participate, join our next webinars. Thank you very much. Bye.
Okay, bye, thank you.